All right, let's begin this show. Thank you, first of all India, for having this wonderful virtual event. I think it's been really, really well accepted and taken. One of the best, probably, of the year. I would definitely go on to say the largest for sure, in many ways, both faculty, registration, and so many other things. Want to thank all my co-instructors. I want to thank Dr. Jeevan and Dr. Priya Narang, who's already here. I think Dr. Partha is also on his way. Perfect. What timing. Thank you so much, Dr. Partha. But we're going to have a really, really rocking time with this one. This is called Overcoming Pitfalls and Challenges in Complex Cataract Surgery. And I know everybody wants to see something or the other from all these stalwarts sitting right next to me. Not literally, I mean virtually, but I'll give I'm going to give this talk to whomever wants to go first. I think Dr. Jeevan, would you want to go first? And we'll go following you. We'll go after you. I think that your talk is going to be on dealing with the unusual cases. So, what have been your unusual cases during this lockdown? Let's hear it out.
Thank you, Ashwin. Nothing much, during your lockdown, AIMS was totally closed. We didn't have to do much things, except for saving ourselves from an attack of this virus. All young people were on, COVID duties. We were spared. So I would definitely show something which is not unusual, but it's a routine thing. We make it look unusual sometimes. So let me share my screen. And thank you, Ashwin, for involving me in your IC. This is my first IC with you. And hope that we'll have many more in future. And seeing Priya and other people, how do I get into my
slide share, sir? Slide share.
Share screen. You'll have to open the application. Yeah, perfect.
But I'm not sure if that's going to come.
Yeah, it's opened. You're fine.
Yeah. Okay. It's there now.
Perfect. Yes.
Okay. Thank you. So I'm going to talk something on a white cataract, intumescent white cataract, which we all encounter in our life. So this is a different type of white cataract, intumescent white cataract, which if you see in a two-dimensional view, which we see through the microscope, you will not appreciate this, what I call hill or some sort of bump. And it is visible when you have a three-dimensional dynamic picture, which is seen through the IOCT. So let me take you through this. And from our side, no financial disclosure for this particular video, or which I'm going to show in this session with Ashwin. So we know that you have a wide range of white cataracts with the different scenarios, and the absence of white reflex makes things very, very difficult. So this is our classification, which is based on our intraoperative dynamics of white cataract. You can see a wide range of spectrum, right from the totally fluid to a no fluid white cataract, or you have a this type of cataract, which is we call it type 2 type of cataract. If you see here, you have a convexity coming towards the anterior chamber. This signifies raised intralenticulaar pressure. And you have a sheets of white, you can see yellow-green picture in IOCT, sheets of fibers which are hydrated running across the entire length of a lens. Then in between you have intermingled spaces which are maybe a fluid filled, but they are inside the entire band of hydrated cortex, which are seen as a hyporeflective areas. You can see an entire sheet. If you inject viscoelastic, this will go down, become little concave, but the pressure will not get released. So this is a type 2 variety of white intumescent white cataract. If you see such cataracts, you have to be a little more careful in doing a capsulorhexis. So let me show you a first case of that type of type 2 variety of intumescent white cataract seen in IOCT. You can see here very clearly, you do have entire sheets of cortical fiber which are hydrated, and you have a spaces in between. though the convexity of anterior capsule was not that significant, I could think that I would be able to do a capsular axis without having to do all those maneuvers to decrease the pressure in this particular case. Let's see how this case goes on. You can see in my left hand side video, I'm trying to make a little small nick. As soon as I make a nick, you can see this hill is starting to come through the small opening. And that signifies the raised interlenticular pressure. And immediately, if you have IOCT, you realize this is going to be a tough case. If you don't have IOCT, you might still feel you can do it regularly because you use high viscosity viscoelastic here. The tendency is to make a smaller capsular axis. No fluid is leaking at that time. Only the hill is coming out. And these five, and I thought I'll inject little more viscoelastic. Unfortunately, the air bubble came and I had to inject much more viscoelastic to take out this bubble out through my side port. You already have Norton's underneath fibers. So I'll try to make a smaller axis with this needle. This flap is important. Don't try to go too peripherally. At this stage, I thought I'll pick it with the island peeling faucet, which I regularly use for my capsular axis. Everything is going all right at this stage because this is, you can see a tear which is radiating towards 3 o'clock. See little more injection of viscoelastic. You have an entire extension coming to periphery, and see the hill is right. Despite this extension, the pressure has not got released. So this is a patient again. I'll show you again here with a little bit of viscoelastic injection. You're going to distribute the pressure from center to periphery, and that will enhance the chances of rexus getting extension. You can see entire rexus got to periphery, and the hill is still maintained, the pressure is still there. You can see what happens now. I'll go with my IA cannula and aspirate this entire cortical fiber, which is hydrated. You can see now, you can see the concavity coming into the anterior part of the lens nucleus. This concavity will help us to do a subsequent maneuver to complete a keyhole type of axis for this patient. So with the ILM peeling faucet, you can see now easily I can make it a little bigger so that this gives access to complete my phaco subsequently without getting difficulty. Let's see another case which gives the way we can manage and decrease the complication. You can see same scenario here. It is always better to stain the capsule with trypan blue dye under viscoelastic cover, and the pupil is moderate here. You can see here, as soon as make a nick here, you'll see that capsule will bulge because of the entire hydrated cortical fiber will try to come out through this small opening. And this will increase the pressure or a tearing edge. Therefore, I'm making a circumferential tearing edge, not let to go too peripherally, be in the central area. You can see this mountain or hill is started coming now, and this is going to make things more difficult. If you see the IOCT here, this mountain is happening because the cortical fibers are there throughout the length of an entire lens, and these fluid pockets are not getting released despite making a nick in the capsule. So these type of white cataracts may not be amenable to aspiration with needle. So these has to be, cortical fiber has to be aspirated in these cases to decrease the pressure. So this, you can see I made this with this going quite all right. At this stage, to have a pressure in the periphery, I'll use a dispersive viscoelastic, which will be retained for a longer period without worrying to sudden leak out of viscoelastic, and capsular pressure gradients are maintained. At this, you can see here, I can inject the dispersive viscoelastic in the periphery so that maintain the pressure, because once you initiate, there will be some release of viscoelastic and the gradient from center to periphery changes. So I'll inject in the peripheral area like you saw here. Then subsequently with ILM peeling faucet, I'll make at least 2 millimeter or 1.5 millimeter excess with little care to pull towards the center. Rather than pulling towards the periphery, you have to pull towards the center. This gives the access now. You see that with aspiration with the bimanual cannula, the cortex has been aspirated, and I have a concavity now, and this decreases the pressure towards the capsule now. So this is how it is important to aspirate the cortical fibers, not the fluid, because no fluid in this type of a white cataract, introducing white cataract. Now I have aspirated both sides, the cortex, the capsule becomes less tense, the pressure from behind has totally decreased. So once I complete the aspiration of a central paracentral area, Then I'll inject viscoelastic. Now you can see my rhexis becomes very, very simple, effective, and you can nicely do a spiraling of this rhexis to a desired size, which will give you access to a nice phacoemulsification of nucleus, which can be soft, which can be hard, depending on the type of white catheter you're dealing with. And adequate size rhexis would be such which gives a good access to phaco, as well as you have a nice coverage of IOL edge, and see how comfortable the rhexis becomes now. In a case of type 2 type of white cataract in IOCT, where the chances of a rhexis extension is very high compared to other types of white cataract, which can be fluid type of white cataracts, where the fluid leaks out and things become easier. You can aspirate with needle, you can do a penchorhexis, you can do any maneuver in a fluid type of white cataract is easier. But once you have a hydrated cortical raised lenticular pressure, the things become very difficult. So that makes challenging, and it is interesting to really see how the entire dynamics of anterior capsule changes with the nick of into the capsule, or a subsequent smaller rhexis you make in these cases. Subsequent emulsification in white cataracts can be easier in a softer cataract like this. This is a grade 3 nucleus. You can do a very nice central nuclear emulsification, take the large piece towards the tip with your second instrument, and you can do a comfortable in the center emulsification of an entire nucleus, and Iol injection can be easier in such cases. So this is to stress how a difficult case would look like when if you don't have access to a visualization intraoperatively, and making things simpler and easier to have a comprehensive outcome for a patient. Once you see, you can do better. So this is what I wanted to express in this particular meeting. Thank you, Aswin, for this opportunity.
Thank you so much. Thank you so much, Dr. Jeevan. I think there was some exceptional pearls there, which you can't take it out. And I think the IOCT is. I mean, we've always been questioning the IOCT in terms of what's the real use, and I think you've really showcased what one of the uses indications could be and should be in cataract surgery at least.
Yeah.
But certain questions that I want to ask Dr. Jeevan, I think. Do you think that I mean any of these procedures do have a hit or miss kind of ratio, but there is one procedure called the femto. How advantageous is it to do a femto in these cases? Because is it extremely important or no? And I know that you have pretty much the whole plethora of femtos in your center, but just
Aswin, you are absolutely correct. Femtosecond devices are really helpful in our difficult situations, and it is useful in a intermittent white cataracts also. Right. There, it is totally different scenario than a manual capsular rhexis. Right. In femtosecond application, if you have fluid type of a white intermittent cataract, you have a higher chances of having escape areas. Your rhexis, the capsulotomy may not be complete. Right. In fact, in manual rhexis, this is the easier part. While the case I showed, in femtosecond, it will be a very simple case because there won't be any fluid leak, and the dimension of a capsule will not change when the laser is firing. Right. So it is good to have a femtosecond in a white cataracts. It definitely gives you access for a good capsulotomy. But unfortunately, in all white cataracts, nuclear softening is not possible because the laser may not penetrate through. Yeah. It is only for a capsular rhexis. In that way, people using other devices like Japto will be similar to a femtosecond in this, with a lesser cost to the patient and institution.
Absolutely, I agree. Yeah. Thank you so much, Dr. Jeevan. I think we're finishing the first talk, and I want you to just stay back as much as you can.
Yeah, I'll be there. I'm free. Luckily, this is the only session I'm free.
Okay, fantastic. Thank you for that. Thank you for that. I'm going to go next because I think there are certain questions that can be asked post this. And I hope my screen is visible to everybody. And
yes, doctor.
Thank you. I'm going to be talking about secondary IOL implantation in challenging cases. But before we do that, I think there are certain indications where we would do a secondary implantation when you have a PCR, zonular dialysis. I don't need to explain this, but you can take this as a snapshot if you want some indications of where we use secondary IOLs. I also want to showcase that the procedure I'll be talking a little bit more about will be the glued intraocular lens, and hence certain instruments that you probably need to or want to have inside the OR. The need to definitely have is a 3-piece lens and forceps, the glued Iol forceps. Everything else is a good to have scenario over here. The marker is something that we devised with Epsilon. I have no financial interest with them way back in 2014-15. And the trocar AC maintainer was made by Mastel. I have no financial interest with them either. I want to talk about a little bit of a plan A. So I love the bag. I like to keep the bag, and I know that comes as an irony that I'm saying this, since most of my talks are always given on glued intraocular lens. But the way that I like to keep the bag is something called as the paperclip hook or the glue dial hook, which basically is a device that is made with PMMA. And here is a case of a subluxation where I've made a flat or a partial thickness flap with a sclerotomy on one side. The distal end of this hook is basically taken out through that sclerotomy or externalized, and the proximal end is inserted into the anterior capsular rim. But before that, I'm placing some capsular hooks in place just so that we can actually stabilize the bag while I'm doing my phaco in this procedure one, and cut the excess distal part of that hook and tuck it in. So that's permanently placed now. I don't have to change it. This basically gives me a full-fledged bag support for intraoperative phacoemulsification, after which I do place my CTR or a capsule tension ring. I like to delay the capsule tension ring to the end or late to the last moment that I have to put it in. In this case, that was at this point of time, just before the cortical removal. Once it's removed, I remove all the capsular hooks, but I leave back that paperclip hook in place. And this device was coined by Dr. Susan. I want to congratulate her for this device. It's exceptional, it's beautiful, and it stays permanently inside the eye, as you can see. And just with the application of glue, I would like to, this is some of the post-operative pictures of day one of the same patient with the hook. You can see the hook is holding the bag in place with the CTR also, and a centered IOL. If you see, the hook kind of goes into the sclera over here, and you can see this on the UBM. But nonetheless, I have to also say that sometimes, even though you tend to do the best for the patient, sometimes what happens is this. I'm doing my normal case, which looks pretty okay. Just a little bit of subluxation over there. It was not even as bad as the previous case, honestly speaking. I mean, what you can see when I'm doing my Rex is that it's starting to move a little bit, and I'm not happy about that. But so I've completed my Rexes here, and I've placed a capsular hook. Now I'm going to be placing a capsular hook in place here, just because I want to be safe than sorry. I've placed my capsular hook in inside the bag, and want to make sure that there is no movement while I'm doing my phacoemulsification. That's a small trick. Nowadays, I've started to put 4 hooks, but earlier it was 1 hook was enough in this small scenario. I did my complete phacoemulsification in this case, and once you go along with the case, you try to understand that you try to get a little bit bolder, and I did get a little bit too bold, and see what happens. Oh, that's not meant to happen. And watch it again. I went for the cortex, which I shouldn't have done, and that too in an area where I know there is a little bit of subluxation. So these are scenarios that I'm not worried to show this, because this happens to all surgeons regardless of caliber at times. And so the first thing I do in these cases is I suture up that wound. I make sure I put a trocar, either anterior or posterior trocar. Once I've made put my trocar in place, I make sure that I use my glue dial marker to make my flaps, because I know that there is not enough capsule support now. I've made my flaps, leave the cortex, leave the bag exactly the way it is. Just make my 2x2 millimeter scleral flaps, partial thickness. Once I've made my partial thickness flaps, I'm making my sclerotomies under the flaps, about 0.75 to a millimeter behind. Direction should be towards the center of the globe, not the center of the pupil. Otherwise, you're going to be pulling iris. Now I've made my corneal wounds. So basically making my side port entry. And now using a vitrectomy cutter and the infusion turned on, I am admixing vitreous, cortex, and bag remnants Along with that, so I'm cutting away and aspirating all of this, either cutting or aspirating between all three, basically completing my anterior vitrectomy and cortical removal in this with this step. You can use the sclerotomies that you've made. You can use the limbal route. Either which way you want. You must ensure that you clear up that space of any vitreous. That's the most important point I would like to say. Externalizing the haptic, very important. Hold the tip of the leading haptic and externalize it. Now using the handshake technique, and I will come to this handshake technique as a separate point later on because it's a very important step in this procedure. Watch it again. Once the leading haptic is outside, I'm basically taking and placing my trailing haptic in a particular position. Once that's done, I'm internalizing my trailing haptic, grabbing it with my left hand. Left hand, right hand goes through the sclerotomy and hold the tip. This is very important to hold the tip of that haptic and bring it out. Otherwise, that flange is going to break. And that's something that we don't want to do. So once this is done, you have both your haptics externalized. Now you make your Gebel Chariot's tunnel. And once you made your Gebel Chariot's tunnel, you can actually just tuck these haptics into that tunnel. Some people have used diamond blades. Some people have used different kinds of blades. Some people even use the crescent knife to kind of leave that haptic in place. I like to use the 26 gauge or the 27 gauge needle, whichever you get. And once you've placed this into the into the Gebel Chariot's tunnel, you basically tucked your haptics right in place. Closing up is pretty simple. You use pilocarpine or you remove your trocars first, put some glue in place under the flap and the conjunctiva to close up this wound. That's pretty much how we like to close up this wound. Of course, you have to do some stromal hydration as well. This is what I wanted to say about the glued intraocular lens procedure, and this is how the post-operative day 3 looks of the same patient. In summary, if you want a snapshot, this is what we do in terms of steps, but I'll go to how do you master this? How do you become better at this? First things first, you can use an anterior infusion also, and that is done by the trocar AC maintainer. If you have flaps, do not make your flaps too large because then you do not have enough haptic to tuck. So don't make them 3 millimeters or 5 millimeters like how you would do in a trabeculectomy flap. This is a 2 by 2 millimeters that works perfectly well for these glued intraocular lens procedures. If you do have your white to white as 12 millimeters, please move over to a vertical glued intraocular lens that works best. Next one is the direction of the needle, the sclerotomy under the flaps. Watch this, guys, very important. The direction of the needle should be towards the center of the globe. Otherwise, what you're going to have is, look at the left one, you're going to have some amount of bleeding like this, and that could abort your procedure itself. And this is a step which is very important. So direction of the needle, don't drag the iris, go behind the iris. That's the idea. And circumferentially make that tract circumferential to the limbus, because that goes along this memory of the lens. That's something that you need to know. Pilocarpine can be used at the end of this case, but make sure that you wash off any pilocarpine at the end of it. If pilocarpine does not close this pupil, and sometimes it does happen that you have an optic or an iris capture like this, if this happens on table, be rest assured it's going to happen post-operatively, and that point of time you won't have anything to do. So what I've started to do in these cases is to do a single pass fourth row or a pupiloplasty of your choice, because that prevents this scenario from happening. Some very special scenarios where you have a 3-piece lens or a single piece, old PMMA single piece lens, which is really good actually, it's just dislocated. You can actually, just making 2 paracentesis wounds, you can refix that same intraocular lens using the glued intraocular lens procedure. The other one I wanted to talk about is the glued IOL scaffold. Basically, it's a very, very transparent lens here, which is subluxated. So I've just put it into the anterior chamber, pilocarpine, bring the pupil down, do my glued IOL behind this lens. And because it's so soft, and this nucleus is so soft and young, I'm able to emulsify this using a phacoprobe at power of 5. So this is the post-op day 1. I'm sorry about the blurred image, but that's just because the camera, not the cornea. Cornea is crystal clear. glued in intraocular lens with endothelial keratoplasty. I'm basically laying a foundation with doing the glued IOL and the pupil plasty. Once the foundation is laid, I can actually place this graft and that air bubble will now not go down. So these are some of the advantages of doing the glued intraocular lens procedure in these cases. I also wanted to show this is the post-op of the step one was 1 month after just glued IOL and then the 4 month after the endothelial keratoplasty. Thank you very much. I wanted to showcase this procedure to all of you, and I would love to have thoughts on this as well. And I will introduce our next speaker after that.
Swin, it was wonderful to see your videos and very good practical points for our young people to learn how to initiate, into a glued IOL, making an incision in a proper place, making a good flap orientation to the direction of needles. Very nicely explained by you. What about like people would do in a different techniques nowadays, like anterior Yamani approach. Yes. Earlier, people used to do suture fixated scleral fixations. So things have evolved, so many ways.
Tremendously.
But I think still the technique of yours or Amar, who have popularized, holds true for most cases. If I see my own or units work in these cases, we have done a UBM studies of all these cases. The lens fixation is very, very good. The tilt is very less if you've done a proper assessment of the limbus to limbal diameter and orientation.
Absolutely.
And the movement of lens is also very less in these cases compared to a suture fixation lens where the lens moves to and fro and cause a lot of CME and endothelial damage in those cases. I think this techniques has done wonderfully well in the last almost now more than a decade now.
Yeah, it's been 13 years.
13 years, yeah.
I think 10 years studies already published the results, the outcomes of that. Ashwin, for the benefit of all, could you just highlight the size of the sclerotomy and the size of the end opening forceps that you're using inside the eye? Because there has to be a match of both.
Yes. You're absolutely right, Priya. And I think I'll give you the historical event also. Evolutionary, we started off with using a larger, used to do it 18 gauge. We moved down to 20 gauge. Now it's come down to 23 gauge and we use a 25 or a 23 gauge forceps, because the more snug that fit is, the better you'll have in terms of closure of the wound, and that flap will not leak any fluid. And that's the most important point to take home from here, because sometimes at the end of it, you might get a hypotony in these glued IOL cases 1 day post-op. That has completely stopped the minute we started to switch over to the 23 gauge forceps and the 23 gauge needle. And if you're making the 23 gauge needle, just while you're coming out, a little bit of a nick just to keep that sclerotomy a little bit more open. These are only few tips that I want to.
Absolutely. And I just wanted to know your personal experience, like when you're tucking the haptic, we are all using 26 gauge. There are some people who are also using the side port and everything, so that they get a bigger area to place the haptic inside. Do you have any experience with the larger wounds like that?
I have seen people use diamond blade, side port, crescent knife, all of this. I do still believe that the needle gives the best tuck because it gives the solid foundation. It gives fibrosis post-operatively is very, very strong. And within 3 weeks, it won't move.
Yeah, the movement of the haptic will be less with that.
It does not keep it open and swaying inside that space. Absolutely. That's the big advantage.
Could we take a few?
Sorry, Pat. Learning curve for young people. You have cases where you have a lens getting dislocated because the fixation was not proper in some cases.
Yes, it has definitely happened. Dislocations are a possibility, and we must know how to maneuver them. In fact, so here's the point. I think for youngsters and people who want to start this procedure young, the point I'll tell is, one is infusion inside the eye. A lot of people try this with viscoelastic, and that's dangerous. and it will not work because viscoelastic vitreous, you will not be able to grab any haptic. You'll not be able to do any of this. The second point I would say is definitely learn anterior vitrectomy. Just basic anterior vitrectomy is required. Whether you do limbal or you do sclerotomy based, doesn't matter. Just learn the basic anterior vitrectomy, and post that, learn these the flap, the trabeculectomy flap. This I would say has been, I wouldn't understand this because I did trabeculectomies a lot before I started to move into this. But when I heard people that they have not done trabeculectomies, they find the flap as the very, very difficult step to move into this. So I would say practice doing the flaps on cadavers and this thing. How do you get partial thickness repeatedly? And that's something that you can really, enhance your skill on. These three steps,
very good point.
Yeah, will change the dimension of how you get to glue diode.
I think it is quite similar to learning any procedure, sir. I mean, it looks so easy when Ashwin does it or when you do it, when Priya does it, but it is actually not so easy. And especially because it is in a plane that is different from what we are supposed to be working at or what we are conventionally be working. So all the logistics are different. The haptics moving up,
Yes.
the optics moving down, the catch, the hold, everything is, it has to be learned. I mean, it's no
It has
short.
to be learned. I agree. And I think watching it right next to somebody rather than on YouTube or on video, I definitely feel that adds so much of layering to it, because you then get the hand positions, you get how people are sitting, all those small changes which I can't talk about on a webinar, but I can definitely showcase it with one-to-one.
Yeah.
Those are
Great.
advantages that we can have.
So a few questions and observations from your presentation, as usual, an excellent presentation, so much learning. And what we used to know about the white cataract, it was more of an art, doing a white cataract, but the science is what you have ingrained into it with the anterior OCT and the findings, and how you have actually structured that the spaces that that are there. So, and thereby this is quite important, and so this becomes very, very important. And of course, everybody does not have the benefit of the anterior OCT, and but still it is important to understand. And even without an anterior OCT, but if one looks through the slit lamp, you can actually understand that this has spaces, and this is one that has more of cortical matter and lead cortical matter. And of course, the importance of the fibrotic capsule in the white cataract is again very, very important, whether you do it with the capsular axis, the manual one, or with the femto one. I've had quite a few of these thick fibrotic capsular axis, which I could not do with the femto with the ordinary energy. So understanding that it is fibrotic, and then the energies have to be so positioned so that it does cut through even the fibrotic anterior capsule. The other thing that initially, I had one or two ones in which it was so milky. It was intumescent cataract, of course. In those, the milk came out so fast, even in that 1.6 second, the capsular axis, there was a place that the capsular axis was not complete. So here again, the staining of the anterior capsule is again very important, and keeping our two forceps, which is so important for these white cataracts, is again mandatory, even if you are doing it with a femtosecond.
Partho, well said. We understand, clinical examination of all cases should be done carefully by surgeon himself or herself, especially in a difficult situations, and see both eyes, because other eye can tell you what difficulties would have had in that eye, or you are going to face. And if you have good access to a anti-segment OCT also, that will delineate beautifully all these pictures which we see in IOCT also. And nothing is less than a good examination by slit lamp by our people. That gives you so much of information. IOCT only helps in it tells you actually what happens when you actually play with the tissue, which is not available with OCT or a slit lamp. But it can give you what you're going to face in that particular case. The examination is a very critical for all surgeries.
Dr. Jeevan, there was one question I wanted to ask you, and I think it's important.
Ashwin, you're muted.
Oh, I don't know if you've done this in RP Center, but I wanted to ask, and I did this, and I just wanted to get a hint from you. When I saw this intermittent cataract, this intermittent white cataracts, I started to do something called as VAP. It's called a vitrectomy assisted phaco. VAP basically means that I go behind the lens, and I know this is a sort of a blind procedure, but this was intermittent where I could see inside. It was intermittent, but I could see it was transparent. So I was able to go behind the lens and do a little bit of vitrectomy for 1,000 cut rate for 7 to 8 seconds, or even lesser. I would say 5 to 7 seconds. That's it. That really brought that whole plane back down, and I was able to do my rexis completely in the first go. I'm not sure if it's right, wrong, but it really worked for me in that scenario. Not sure if it's. I wanted to know your thoughts, everybody.
Ashwin, you're absolutely correct. People have done it, like especially phakomorphic glaucoma, where you have a intumescence, shallow entry chamber, difficult working in a space-wise. So people have done vitrectomy in these cases, as you rightly said, and that makes very simple procedure subsequently, because you have a softer eye, the lens diaphragm goes down, you can do all manipulation very easily. But that adds into another procedure for a surgeon. But if you can handle the routine cases by as an anterior segment surgeon, that should be a better way. But difficult cases, what you're saying is absolutely correct. But sometimes people give mannitol before surgeries. They initiate so many things. But simple, even people just do a sclerotomy. And just a tap and few drop of fluid comes out, even that would decrease the pressure immediately. And if you can finish the case within 5 to 7 minutes, that suffices.
Absolutely.
Dr. Tityal, I wanted to ask you one thing, that have you ever tried doing punchorexis that Dr. Mohan Rajan had said? Because what I feel is it creates a big hole, it creates a big dent, it might pull up many of the fibers from inside and might dramatically reduce the pressure. Have you ever tried and analyzed it on OCT, intraoperative OCT?
Yeah, Priya, frankly, we have not tried punchorexis. And especially the type of case I showed, type 2 variety, as I said, it may work in these type of cases. In a routine fluid type of intumescent white cataract, punchorexis has no advantage there. Their needle also suffice. But this type of white cataract, where you have a sheet of hydrated cortex across the length of a lens, there it might work. And you rightly said, I might try in some cases, see, because it will take out the entire bunch of hydrated fibers and decrease the pressure immediately. So these are cases where it might work.
Thank you, Dr. Tityal, for those answers. I think they've helped so many people who've been watching this. And I want to invite now, somebody who's very special to this whole program, to the whole of AIOS, who, behind the scenes has been working extremely hard. I mean, it doesn't show right now, but I know how much he's worked for the last 1 year towards this one program called the AIOC2021. So the man behind the show, the man behind everything, Dr. Partha, can we please have you to present your topic, Iol Exchanges. Are you there or you left us? Dr. Partha? No? Okay, I will do the introduction again later.
I think he's gone for other session.
Yeah, no problem. Dr. Priya, do you want to go next?
Yeah, I can.
Sure. Thank you, Dr. Priya.
Okay.
I'll give that Partha's introduction again. And Dr. Priya is from Ahmedabad, and she's an exceptional surgeon, does one of the most aggressive, probably most bold surgeon I've seen in recent times. So off to Dr. Priya to talk about difficult iris repair management.
Thank you so much, Ashwin, for this wonderful introduction. So I will be just talking. Ashwin wanted me to cover up iris repair management during cataract surgery. So I will be covering up those. So briefly now, when we consider whenever we want to do an iris repair, it is usually two types of method that we have repair. The first one is the pupil-centric method. That is where you try to create a pupil with appropriate centration. The second thing that we usually do with the irises is that, we need to do the iris-based repair, and that is what we call it as an iridodialysis repair. So these are basically the two major kind of iris repair procedures. And then comes in more complicated cases, then we go ahead with the combination of both these that is applied clinically. So first, I will just highlight the pupil-centric method, and that is the single-pass 4-through biblioplasty procedure, which we are now using commonly. This is the animation of the video that showcases how this procedure is done. We use an polypropylene suture. It's a long arm needle, which is passed from the proximal end of the iris tissue, goes from the distal end, and you just go through the side port. You create a suture loop, pull this suture loop out, and the end of the suture is passed through the loop 4 times. 4 times is the most important aspect of doing a single pass 4-through, because that is where the suture holds onto it, and you do not have to redo the procedure. You do not have to take the second throw for this surgical procedure. So that is how it derives its name as single pass 4-through biblioplasty procedure. Now, when you apply it clinically, I will just try to show you cataract surgery, which has been done. The lens fixation has already been done in this case. And now this is the clinical application of the single pass 4-through biblioplasty procedure. Having passed from the proximal end, now what you see is that the distal end of the iris tissue that is to be approximated is whole. Now, at this stage, you have 2 options. Either you can pass the needle directly from the distal end and pull it out, or you can also railroad it with the 26 gauge needle, and then you can go ahead with the surgical procedure. Creation of this loop is very important. Through this loop, the suture end has to be passed 4 times in the same direction. You do not have to change the direction. Otherwise, what it happens, it undoes the procedure that you are doing. Your throws will be less. If you go ahead with either a 3 or a 2 loop, it is going to open up and you have to take a second pass. So if you just want to end up this procedure with a single pass, you just have to take full 4 throws, because in the lab study, we have found that 4 throws are the most optimal kind of thing. It will stay back even if you take a 5 or 6 throw, but that adds to the bulk of the suture material which is there inside the eye. You can repeat this procedure till you have the iris defect totally covered up. So this procedure actually it works very beautifully, because you just have a single pass. There is less manipulation for any one single side that you need to approximate in the iris tissue. Just a single pass works very well through that. So there's a minimal intraocular manipulation, and definitely that translates into lesser inflammation in the postoperative period. So this is one of the pupil-centric method, which we call this as the single pass 4-through biblioplasty procedure. Now we go ahead to the second thing, and that's the iris repair. Now this is a modified sewing machine. This surgery I have just done a few days back last week. So I thought, let me edit this and let me show it to you. Have a look here. We have the iridodialysis, and it's quite big. So before we take up this case for a cataract surgery, I first like to do a cataract. Because when I do the cataract surgery, I'm just decompressing the anterior chamber, and then we go ahead with the iris repair procedure. So just that the iris tissue does not fall back when you're doing a cataract surgery, you need to retract the iris tissue from there, and that's why the iris hooks are used. I would always say that iris hooks have to be used. They are best because it's an external fixating device, and rings I do not usually recommend in these cases, because these are usually complicated cases, and hooks, they work really very well. Now this is the animation of modified sewing machine technique. I just paused this here. What you are seeing here is this is a 26 gauge needle which has been threaded with the suture, with the same polypropylene suture. It has been threaded. Now this works as we create multiple loops out here. Now there are 2 methods. One is the sewing machine technique, and one is the modified sewing machine technique. In the sewing, this is the modified version, wherein the one end of the suture is passed through all the loops, and then it is tied with the last loop, so that you finish up the entire procedure with just one. Just once you have to take a knot here, and your entire thing is done. You can even do a modified version. Sorry, not a modified version, but you can even do a simple sewing machine. But there, you have to cut down those loops and keep on suturing one with the other. So in order to avoid multiple suturing, you can do this. Now you just have a look. This is the clinical application here. This is the needle which I'm just threading with the suture. And so you are just ready now to do the procedure. So you just do a conjunctival peritomy, you create a scleral groove all across the area where iridodialysis repair has to be done. So having done, because we are going to pass on the suture into this groove and we are going to bury it inside. So now this is the threaded needle. This threaded needle comes out from that groove and you just have this loop. So you just pull this and now you'll have a loop, but just because this is the first suture that you are taking, you will get one end free. So you just pull that out and then you keep on creating multiple loops. You go back inside, take the adjacent iris tissue, come out from the groove, just pull this again. So you have one loop out here, again go back inside, and again you engage the adjacent iris tissue and you keep on doing till you have the entire iridodialysis area covered up. One important thing while doing a sewing machine is what I learned from my personal experience is that, you know, when you're going ahead for the second loop, you have to be very careful that, you know, when you are, your previous loops, they don't slip back inside, because there is a tendency, because all these sutures are interconnected with one another. So when you go for the second loop, there is a chance that you might slip on. Now see, this suture has slipped on. If you noticed what happened just now, this thing I did not realize intraoperatively. I realized it when I was editing the video that, madam, I just had one slippage of loop inside, which I did not even realize that it had happened. It did not matter much in the surgical outcome because actually everything is interconnected. So once you pull this loop, it stays back and they're interconnected. So it's going to remain in place. So that's not an issue, but that area just went off. So after that, I was very careful, taking care of all the loops that had come out. And you need to pull out much more of it from the section area so that, you know, even if it slips a little bit, you can just pull them out again. Then you have to be careful when you're taking the last thing also. And then when you have the entire thing out, you just have to pass the suture end through one loop. This I'm just forwarding the video here. You pass from the second, third, fourth loop. And then as I showed in the animation, you just end up tying all the sutures and you're all done for this. The second most important thing is when you're doing any iridodialysis repair is the calibration of the tension that you are putting on the iris tissue. That's very essential, because if you tend to pull up too much, you know, it can cause retraction of the iris. Now, I had a bit of retraction here. It can happen because of two ways. Either you have engaged too much of iris tissue in the needle, that pulls it out, or what actually happened was that the tension was not calibrated properly. So then that can happen. So what I try to fix this up by doing a single pass Biblioplasty now, because I know that I have to make my pupil also central. It's not that I have to only correct the iris base. I cannot now release my iris base repair. So I have to fix up the iris, the center of the pupil, and try to make it centric, because this is a young patient. So having done that, having created this is my pre-op and the post-op image. It looks pretty good. The patient is a young traumatic case it was and looks very nice. So this is how it settled down. So this was one of the things that I really wanted to highlight. Another important thing that I'd like to show you is that, you know, for the repair, we usually use the hangback technique, which is described by Dr. Snyder. So many of the young people, they have this issue of engaging of the corneal tissue into the suture needle. So when you have that, you know, what actually happens is that your suture does not slide back inside the eye. It gets engaged into the iris tissue and your procedure entirely fails. So if you have to prevent that, you can place this trocar. This we just published in one of the peer papers in the European Journal. You can use this trocar. You can guide your needle through this. If you are an amateur and if you really do not, you're not very careful about how you're not engaging the corneal fibers inside the needle, then you can use this. If you're an expert, you need not do this. You can just go ahead and do a simple hangback technique and you are all set. So this is again one complicated case. So I just wanted to show you how the application of trocar works for the hangback procedure. So now you can just see how beautifully that loop slides back and it holds the iris tissue into place. And then you just again calibrate the tension before you tie the knot. Calibrate the tension. That's a very big learning point in iris repair tissue, because that is what leads to retraction or it leads to correctopia. So that you can just avert this. I'll just try to show you, these are just animations which I'm just trying to show you for the clinical application. This is again a combination of handbag technique with single pass photocopier procedure. The two-pore technique. Initially, the iris repair was done with that, and then to have a pupil-centric, the central appropriate centration we try to do and combine this with the single pass photocopier procedure. Either procedure can be done. Either you can do a pupil-centric method first, or you can do the iris-based repair later. It all depends upon the clinical situation. This is another example where you have a big defect. You can close down the defect with single pass first, and then you can do a iridodialysis, handbag repair, and then you're all set for this. So these are various permutations and combinations that you can do, and these are some of the most useful methods in iris repair as of now. So I think I tried to cover how much I could. Thank you so much.
Yes, Priya, you've covered more than enough. I think a lot of people are going to be Googling your name today after this presentation. So thank you so much for that.
Thank you.
We definitely have a few questions. And I think the questions are, so pupiloplasty over the past 5 years, I think has become a hot topic of conversation, at least in conferences and other places. But I think some of the advantages you already spoke about was purely based from correcting the defect. But I think there have been other advantages of refractive changes that are pre and post. There are changes of intraocular pressures pre and post. There are changes that we talk about, different things. What are those changes? What are the effects of pupiloplasty? If you can just...
there are many.
Yes.
Yeah, just 1 minute. Ashwin, if I could share my presentation first and take up the discussion.
Oh, yes, sure.
If you don't mind.
Yes,
please, if you don't mind.
No, please go ahead.
So we will now have Dr. Partha, who basically has been conducting this whole AIOC 2021. I cannot tell you how much work this man has put into this event. It is unbelievable. It is, I mean, like 400 sessions in 4 days. It is mind-boggling how one person can do so much in 24 hours. Thank you so much.
It's a whole team work, Ashwin, and I am so thankful to not only my team scientific committee, but every person who has a scientific presentation has started on time, and yesterday we absolutely ended in time. Today again we started in time, and I'm sure, God willing, we should be ending in time as well.
So, all yours. Is all yours.
We actually see that Partha never sleeps.
I'm pretty sure.
Oh, Sonu is there. Sonu doesn't. I don't let Sonu sleep as well. That's what he meant to say.
So Dr. Partha will be talking to us about Iol Exchange made easy. All yours, sir.
Yeah, thank you. So the intraocular lens exchange and made easy. Of course, we have so many techniques now, but we'll let us come to the indications. And the indications are so many. However, incorrect biometry is one indication where a lens exchange becomes nearly mandatory, which leads to gross refractive surprise for so many reasons. The optical aberrations, again, something which we used to put under the carpet 10 years ago, is becoming more and more significant because people are demanding more. We are aspiring for more, and we are promising for more. So thereby, if the optical aberration is significant enough to interfere with the person's daily activities, it is important. If it does not meet our promise, at times we need to go in for an IOL exchange. If there's a subluxated or a dislocated IOL or an IOL opacification causing visual symptoms, damaged intraocular lens, or ongoing secondary tissue damage or other visual symptoms, then is the time for an IOL exchange. However, suffice it to say that we don't exchange an IOL in a hurry. We wouldn't like to exchange it in a person who is comfortable otherwise, even though he might have suboptimal vision. We would not be very happy to exchange it in somebody who has a little bit of psychological inclination or a psychiatric inclination, and possibly is overreacting to a particular situation, because even after an exchange, the person might still not be happy, even though the difficulties might have abated. So the fourth thing is, if of course there is a possibility that the exchange is going to improve upon the visual outcome of the patient, we definitely do go in for an exchange. So a few techniques that I would like to share with you and for the Iol exchange. So this again is technique number 1. And here, this IOL, it broke, the haptic broke, and it was there inside. So the primary surgeon left it there. We went in, we wanted to take it out because it was causing a sunset syndrome. So what we did is we cut this haptic, and here I'm going to pause on a few important parts. And it's important that you don't need to cut the whole of the optic, half and half, or bisect it. It can just be cut or severed into the optic can just be severed, and it just does not need to go directly to the end. Just half in, it will do the job. What happens is it debulks the optic thereby, and when it is pulled out, the optic itself crumples out. So this crumpling effect can take place if the optic is severed. So, and then you can, through this 2.8 millimeter incision, you can place in another intraocular lens. Let's look at this technique. And in this technique, again, this intraocular lens is coming out. And this is, again, a single piece lens, which we are removing. So once removed, it's imperative that you use high quality, high molecular weight viscoelastic into the anterior chamber, protect the corneal endothelium. It is important, again, so that the optic here, look at this optic. Now, this scissors is what it is doing is actually, it is increasing the incision angle. Thereby, there is viscoelastic that is coming out. So it's important that you be very, very careful about the scissors. You don't want to lose the viscoelastic while you're removing the haptic and the optic. Again, as you see that it is only half severed, and this optic folds upon itself to come out. So you don't need to increase the size of the incision at all, and it very, very nicely comes out. So the next, of course, intraocular lens can go in, and that is it. Now let's look at this third technique or the third instrument that we'll be using for this. And this instrument is the better quality instrument. Now, what we have done is we have rotated it so that it is vertical. And these scissors, as you can see, they are simply going in horizontally. Now, look at the orientation of the scissors. This is a must scissor for every cataract surgeon doing an intraocular lens implant, because this is one of the best scissors when the time comes to remove the IOL by cutting it. So these scissors work wonders, and you can really do a good job very fast. So because it has teeth that are very, very effective, and it comes out well. So with this, again, removing it, and you can go in and, just snip, and it will not slip away because it will cut very well. And then you can remove the optic quite gently. In fact, it's quite gentle for the tissues while you're removing the optic and the haptics. So this becomes a very preferred instrument for the removal or the cutting of the intraocular lens. Of course, all of these are single piece acrylic hydrophobic or hydrophilic intraocular lens. Now, I always show this video of
IOL explantation.
Wonderful surgeon.
Easy?
And
My video
Dr.
editor
Arup Bhaumik's video, which won the Best of the Best award in the academy. And what he shows is how a snare can actually remove it. So he puts in the snare and removes and cuts the intraocular lens into half, and that does the job. So this is a very, very unique technique, which can be learned. Of course, again, for all techniques, these techniques need to be learned. And look at the way that this single piece lens is simply ejecting inside the hub of uh, the, uh, the cartridge. Now, I just wanted to show a quick video of an ICL explant also, because ICLs are also intraocular lenses. So it is quite simple, but it has to be done the right way. It has to be done atraumatically. The high molecular weight viscoelastic needs to be there and to be removed at the end of the surgery. Helon can be used because Helon comes out in a bolus, and it is a better molecular weight, high molecular weight substance. And once it is done, then again, if the lens has to be exchanged by another ICL, that too can be done quite well. And removing the ICL is important. What is very important is your forceps have to be in good maintenance condition. Otherwise, what might happen is that it will slip and you will not be able to remove it. So this is the point where it usually slips, and you have to be very, very gentle with it, because the tissue is important. And also look how it very, very nicely folds upon itself and comes out, and there is hardly a mark that is left on this ICL that it has been removed. So, and it does not tear usually. So it's very important that these ICLs be removed in the right way. Now, the last video that I would like to share is doing a sulcoflex. So whenever there is an intraocular power that has caused a surprise, and the lens is very much in place, and you need to place another lens so that it corrects the refractive error, the sulcoflex is a very, very nice lens which can really correct very well, both for toric lenses, as well as they have the presbyopic platform, and of course the spherical lenses as well. So again, this technique is simple, and there's nothing much of learning in it, but I would like to share with you that it's important that the sulcoflex goes the right side in, and it should be placed as atraumatically as possible. Because let us remember, we do not have much of space, because one intraocular lens is already in place, and the sulcoflex has to be placed very gently so that it stays there in place. So this is it goes in very atraumatically, but of course there should be no synechia. We relieve the synechia as you saw, and once in there, it settles very well, and these lenses correct the residual either astigmatism or the sphere extremely well. The technique is not very difficult, can be done very well. The lenses are expensive, but again, it's worth the expense, I think. So this is so much for the presentation that we had, and thank you very much, Ashwin, for your having me in this course of yours, which is such a nice course. Thank you very much.
Thank you so much, Dr. Pata. And I think one question, that probably baffles me, I've had this problem, and that's why I asked this question. When we cut the lens into half and try and remove this lens, Doc, sometimes what happens is there is some amount of bleeding that happens because of some iris touch or the root touch. I'm not sure if you've faced this before, but I have. Is there a way to avoid it?
See, actually, again, trauma to the tissue is what has to be avoided. And you said very importantly that this does happen, especially because the tissue at times, the iris is coming in, and you are encroaching onto the root of the iris. All these things are there. And at times we are not careful enough. So when it happens, first, let me tell you, when it happens, what to do. I think the best way to do is to fill up the anterior chamber with viscoelastic. Give it a good pressure, and wait. What we are all the time worried about is how quickly I can do the procedure. But this is one point of time, I think masterly inactivity with the viscoelastic, nicely tamponading is so important. So it is important to wait 3 to 5 minutes also with a good tamponade, and then gently take out the viscoelastic so that most of the time it settles quite well and you can do off the next part of the procedure.
I'd like to add one thing to it. Many times what happens is, you have to also stabilize the intraocular lens when you are cutting it. Many times when you are cutting the lens, it does happen that, the IOL keeps on dangling. So it is always good to stabilize the intraocular lens from the side port incision. You can either hold it at the optic haptic junction from your left hand, and if you're a right hand person, you cut with the scissor in your right hand. So stabilizing the intraocular lens in the anterior chamber is a very important aspect in order to prevent the dangling and the flipping of the IOL inside the eye, because then you have to prevent the endothelium, you have to prevent the periphery of the iris tissue and the angle also. That is from where the bleeding often happens because of the inadvertent pressure or rub which is coming up.
Quite true. Absolutely agree with you, Priya. In fact, in the videos, I showed that the side port was holding it up, so that actually you have to work after something, I mean, against something. So if you're working against a tissue, then, we cause a tissue damage.
Absolutely.
So that's very important point you brought up.
And maybe the eye is already inflamed at that point, because when you're doing an Iol exchange, there has to be a reason why the Iol exchange is being done. So unless and until it's a refractive and you have done it, otherwise, if you have any complication and you're doing an Iol exchange, you might already have an inflamed eye. So you need to be much more careful when handling the inflamed eyes.
Mm-hmm. True.
Dr. Titiyal, do you have a question for Dr. Partha? I know he has to leave for the whole AIOS is waiting for him.
I have to be on time. If I'm not on time, I get slaughtered.
I'm of course. No. But Titiyal, do you have anything for him, or we can? Okay. Thank you so
nothing much. He's shown a very nice technique. Only consideration in these cases, apart from associated damage to the surrounding structures, endothelium can be very, very compromised in these cases. So that needs a protection. Maybe a little bit of a cushion or Arsenault's technique can be used there. And I always say, if you have to remove the lens, make sure you don't damage the posterior capsule beforehand. There are many people, they have a multifocal lens, patient not very happy. And the first thing they do is that they do a YAG laser opening of the posterior capsule, thinking that posterior capsule may be the culprit. And that makes very difficult for next surgeon to exchange the IOL, because you have a total opening of posterior capsule, vitreous comes out. Then you have to shift to shift the patient to either Priya or Amar or Aswin to do all those procedures.
All those jugglery.
To your point, Dr. Titiyal, I think you brought up a very important point on the posterior capsule. I think to prevent any touch to the posterior capsule, placing an intraocular lens before you actually remove or explant the lens has prevented a lot of problems. It's also called a scaffold, popularized, of course, by newcomer. But I think the point over here is placing an intraocular lens before, whether it be a glued or a normal lens, placing that lens has prevented a lot of problems.
Absolutely.
Correct. Absolutely correct.
Yes.
So having said that, thank you, Dr. Partha. We will let you go. We still have to get back to you, Priya.
Yes, to Priya. Yes. Thank you. Thank you so much, sir. Thank you very much, Priya. Thanks a lot.
Thank you, sir. Thank you so much.
All the best, Partha. You're doing great work.
Thank you, sir. Thank you. Your blessings, sir. Thank you.
Dr. Priya, I'd asked you a question just before this. I think important effects or impacts of pupiloplasty, or in particularly the one you're doing is single pass. So what are the impacts that have had apart from correcting an iris defect?
Absolutely. There are multiple applications of this procedure that we have already published. What I covered up in my presentation was the basic iris repair, which is to be done. But there is much more to it if we analyze this particular method. The first thing is for the urate cevalia. There are the persistently dilated pupil where you have a fallback of the iris tissue. So these are the cases, especially following the penetrating keratoplasty where it has been reported initially, but now we have seen it after many intraocular surgeries where you do not have an explanation as to why the pupil is remaining dilated. These are the cases, they end up with raised intraocular pressure. You don't have to do much. The only thing is that, you have to diagnose these cases that, okay, these cases are probably going into the Uretz Valley kind of thing. The initial and the most important thing that you can do in these cases is to do a surgical pupiloplasty. I would like to add to this because there's a lot of controversy over it. The fallback of the iris tissue will be prevented by doing a pupiloplasty procedure, and you prevent it will enhance the trabecular meshwork. It removes the physical blockage of the angle structures. Now this works when it is done in the initial stages. If the patient has been waiting around and coming around after, I've seen many surgeons, they say it's not working. Maybe it might not work if the trabecular damage has already been done because of the persistently dilated pupil, maybe over months or maybe over years. So it doesn't work there when already a trabecular fibrosis is set in. But when, if the surgeon is aware, if the surgeons are aware, and if you diagnose this initially, and if you do a surgical pupiloplasty, you are all set and you are all done for that patient. And these patients, they respond beautifully. The second application that we have about this that we have analyzed is definitely what has been popularized by Dr. Amar is the pinhole pupiloplasty procedure, wherein multiple approaches are needed. So this is where for higher order aberrations we are using it, and we have already published, and even at that we have done it with the clinical trial suite machine, and we have analyzed the photopic and the scotopic vision of patients and all. So having a pinhole, creating a pinhole. Especially now, if you come to the Indian scenario, we do not have any pinhole IOLs in our country. And that's the scenario in many of the countries worldwide. So if you do not have a pinhole IOL with you, and if you want to optimize the outcome, and if you are very good in iris repair, you can do it for your patient. There's nothing great about it. So pinhole pupiloplasty works very well. Only thing is that you will need multiple approaches. You will need a concentric approach because you need to do it from all the three sides and try to achieve a pinhole pupil. And it is there's a specific set of protocol that you have to follow when you are doing a pinhole. So that's another application for higher order operations. Patients, they come up beautifully. I have seen it myself in my clinical practice. I have operated 2 patients of RK, and we always know that there is always a refractive surprise coming up in these cases, even if we try to optimize as much as we can the IOL power and doing all the calculations that we usually do for these cases. So initially, when in these cases, I have analyzed in my own practice with 2 cases of RK where we have used a pinhole device with different, with Dr. Holliday's pinhole device with different pupil sizes, small 0.5 to 4 millimeter grading is there. So these patients, they have a beautiful vision, usually with 2 millimeter size of pupil or 1.5, they are the most happiest. So if you can optimize that to these patients intraoperatively, they work beautifully. And I think that's one of the major applications of this surgical procedure. For higher order aberrations where you don't have anything else to do, you do this, and the patients are very happy with that.
You're right, Priya. And Dr. Tityal, have you used pupiloplasty for any of these other alternate indications or only for iris defects? And if so, what are your thoughts on that?
Yeah, Ashwin, I don't get such tricky cases in my department, but yes, it has its applications. Whatever we knew that right from the beginning, we had started with the contact lenses to pupil design contact lenses to decrease all these aberrations, especially aniridia patients, and it works wonderfully well in those scenarios.
Right.
Earlier, using other, like people use pilocarpine to begin with, which had its own complications and problems. And many cases in my younger days, I was very fond of these contact lenses, pupil device contact lenses.
Yes.
The same concept has come to various intraocular lenses also, and now the simple technique of making a pupil smaller is going to work wonderfully well in a difficult cases like a very irregular keratoconus or a post-RK patients where you have a lot of aberrated corneas. It would work wonderfully well. But the concept which Amar and Priya has always floated that that can also decrease the crowding in the angle area, especially if past formation in these cases. But only thing, you need to really assess these patients long term, because if you have a pass for a very, very long term, then it will already would have damaged the trabecular area.
Absolutely.
But yes, it will definitely open up. Especially, I find very, very, effective use of this in a post-keratoplasty synechial formation in the post-graft junction. It is going to work very well in those cases, rather than in chronic ACG patients. These are cases where you have its application. And I've seen one or two cases where we tried and worked very well, looking into a peripheral angle areas, and immediately decreasing the chances of graft getting failure, because once you have a jipping, the entire iris jips around the host graft junction and creates a very difficult situation. So wonderful application in these cases.
Dr. Katyal, you had spoken earlier about flax being used in difficult situations, and we just touched upon only the intumescent cataracts. But where else do you find flax extremely beneficial? I think it's going to be important because flax is here to stay. It's not going anywhere, and I think the indications are going to probably come out more and more over the years.
Absolutely. I find, it is very useful in a subluxated cataracts, because in cases where, I have done in a almost hanging type of lenses also,
Right.
because you can do a nice capsulotomy in these cases. I had one or two cases where a vitreous was then in the entry chamber. There also I could do a capsulotomy and then do all those, stabilization of bag with the lens hook, iris hooks,
Right.
and complete the phaco in these cases. So another group of cases where I feel it is really applicable is subluxated, where you have enough anterior capsule visible for your adequate size capsulotomy to be done. And it works wonderfully well, because the entire procedure of capsulotomy, nucleus softening, and incisions are done without opening the anterior chamber. Otherwise, in subluxated cataract, as soon as you open the anterior chamber, entire dynamics of the subluxated lens changes, and you can increase the subluxation and
Right.
from the anterior chamber. So unless you do a vitrectomy, you can't do a capsulorhexis manually.
Absolutely.
So there is the advantage of a femtosecond application in these cases.
Right.
And other area which I found, my internet is not working well. Can you hear me?
Yeah, you're fine, sir. No problems. You had a little bit of a glitch, but it's fine now. It's
Okay.
working.
Other area which I have worked quite along with, cases of posterior polar cataract, all types of posterior polar cataract. This gives you a very nice nucleus, you can say, safety rings, and also gives emulsification of a nucleus becomes very easy. So you can take nucleus layer by layer and maintain the epicortical cushion for a longer period. In fact, you can customize your epicortical cushion in a different types of posterior polar cataracts.
Right.
So that another area which I found very, very helpful in these cases. And otherwise, femtosecond access is useful in all type of cases.
Absolutely. Yes.
Not only physically for our surgeons,
No.
it is also useful psychologically for our patients also, because they feel they have undergone something
Absolutely.
different.
Yeah. Absolutely.
Many of my patients, they say, I just want femtosecond only, for nothing,
I mean, to an extent, even they say, why are you coming close to me? I mean, the machine's doing everything,
Yeah, that's.
So yeah, that happens. Priya, there was a question that I wanted to ask you regarding the knot on the single pass fourth row. It was earlier said that the knot that was used were 321, 311, and stuff. Now we're talking about just one pass and fourth rows. Has it made a difference? Have you ever had a release of this knot? And what are the tips and tricks that you can tell that, okay, now it's fixed and we don't have to worry?
Yeah, Ashwin, that's very good. Actually, it's there's a lot of inhibition at a mental level that you do not feel secure till you have done 2-3 knots and you have just that it does not open. So that's a fear that is always there in the mind. So for the single pass fourth row, as I said when I was presenting, that I actually happened to do an analysis in my OR in the eyes that accidentally it was found that at times the loop used to open, at times it never used to open. So when it never used to open, it was always 4 or more than 4 throws. If the throws were less than 4, it would tend to just loosen up those interlooping. It would just loosen up, and then you would always have those two cut ends, anytime slipping back. So that was the thing. So 4 throws were found to be optimal, and that is how the name was derived for this. Now, what actually happened was that this was inadvertently, it came up as a single pass 4 throw, which I coined the term. And as we had an interaction with Dr. Jack Holliday, and he said that, what actually you guys are doing, it's actually a timber hitch. A timber hitch is a scouting program. They teach in US to all the scouts how to tie the rope to the wood and all that. And he said, this is a timber hitch, and that is why it is working, and that's what we're actually doing. So we published on this in the JRS also. So that is how we also call it as a timber hitch thing, which has already been in use, but we were not aware of it. So that is how it actually works. There was a claim that people used to say that, okay, actually this is something like a seep search, but seep search has a double throw, and the initial only 3 throws they are taking, and they are taking 2 passes or 3 passes. So it's not exactly a seep search kind of thing. It's just a different entity, which I would not mind calling it a timber hitch also.
Absolutely. Yes, and I think we are going to be closing this session sometime now. And thank you so much, Dr. Titial and Dr. Priya, for being here all throughout. And
Ashwin, can I add one point?
Oh, absolutely, sir.
Yeah, thank you very much, Ashwin. And I was listening to all the talk. It was very good. I just want to add to what Titial said. I think flax is very, very useful in all the complex situations like brown cataracts, polar cataracts, subluxated cataracts. But more so, I feel that today's scenario, I would use flax for a patient who has got a soft cataract, who comes with 6'9", 6'6" vision. These patients, you cannot afford to have any trouble, any problem, because these patients are coming because they got decrease in the contrast sensitivity, and that is the reason why they're coming with fairly good visual acuity, 6'9", 6'6" to you, and you cannot afford to go wrong anywhere.
Expectation.
I'm talking about the neither here nor there cataracts, NHNT cataracts. Flax works wonderfully well. So I think flax has got a fantastic extended indication, I would say.
Dr. Mohan, we remembered you for your Panchorexes also.
That's true.
Thank you so much. Thank you so
I think it should have been coined, Mohan Rexes, So your punch will be much stronger there,
Yeah, sir. Nice seeing you, sir. Again.
Thank you so much, Dr. Mohan, for those last few comments. And I think we'll be closing this session because the next session is going to start in another few minutes. But Dr. Titial, Dr. Narang, and Dr. Partha, please, thank you so much. My warm welcome to AIOS as well for having such a beautiful virtual seminar. They have 18 halls. It's absolutely stunning how they could organize something like this in such a span of time. Because I know a couple of months back, it was all going to be live, but the second wave has just put everything on back foot, and they've gone onto a virtual platform. It's beautiful. Thank you so much for doing this and having this IC.
Thank you, Ashwin. Thank you.
Okay. Thank you, Ashwin. Nice one.
Thank you, doctors, for the wonderful session.